Buongiorno, come stai?
Buongiorno, ciao Philippe.
Ciao,
Thank you for joining.
my pleasure. Thanks for the invitation.
Thank you.
No, I know how busy you all are with scientific and academic duties, and so we really appreciate your availability to share your knowledge with us.
You know,
We
Luigi,
have.
we never say no to a friend.
Thank you very much. We have more. We are close to 330 registrants, so it seems.
Wow, that's cool.
Well, the faculty is stellar, so people joined without any reservation.
I like stellar. You can if you can talk to my wife, that would be great.
I will send you a certificate. Hi, Becky. Thank you for joining.
Thank you for having me.
Hi, Becky.
Hey, Anna, thanks for the email, because I wouldn't have been on it. But
No problem. It was, I guess, a common problem. So
I think, yeah, you needed to register first to get the link. That's what I
Yeah.
realized yesterday, actually.
Sorry for that. Okay, I think it's time to start.
yeah.
Buongiorno a tutti. Oggi sono particolarmente contento di essere qui con la dottoressa Anna Sannino a moderare questo che è il primo webinar del gruppo di studio sulle cardiopatie valvolari, e come primo webinar abbiamo invitato 4 fra i più grandi scienziati nel campo delle valvulopatie. Il webinar sarà in inglese, loro sono colleghi ovviamente stranieri, per cui permettetemi di girare in inglese. So thank you, Maurice, thank you, Phil, thank you, Becky, for joining. This is the first webinar of the working group on valvular heart disease of the Italian Society of Cardiology. There are 330 registrants for this webinar, so you were able to attract a lot of people. Let me just make a very short introduction before starting in order to put the webinar into perspective. And I would say that over the past decade, 15 years, there's been such a significant progress in our understanding of heart valve diseases and their impact on patients' quality of life and health. New and less invasive treatments have also become available, allowing patients who were previously not eligible for surgery to receive treatment. As a result, our feeling is that the timing and the method of repairing and replacing the damaged heart valves is continually evolving, and the scientific guidelines cannot keep up with the pace of the new evidence. This is the reason why the working group on valvular heart disease of the Italian Society of Cardiology has invited 4 leading experts in the field to provide an update on the latest treatments for aortic stenosis, mitral regurgitation, tricuspid regurgitation, and aortic regurgitation. Dr. Sannino and me are really grateful to them for taking time away for their clinical and academic duties to share their knowledge with us. They are real friends. Let us start from primary mitral regurgitation, and it's my pleasure to invite Maurice Enrique Serrano. And the question is very simple and very difficult, Maurice. What we have to do with those patients?
Thank you so much. Let me find if I can share my slides. Let's see if I can. I'll be sharing in just one second. And let's see, here we go. Share, you see the slides?
Yes, now we see them.
Perfect.
Very good. So, Professor Badano, Dr. Sannino, it's a great pleasure to be here. Un gran piacere to be here with the Italian Society of Cardiology to discuss primary mitral regurgitation. Primary mitral regurgitation is due to organic valve disease of the mitral valve. And in the current epidemiology knowledge, in the community of mitral regurgitation, 2/3 are functional, 1/3 is organic. And the vast majority of patients with organic valve disease in the Western countries, in the high income countries, is degenerative. And so we're going to be focusing on the degenerative MR. Degenerative MR is characterized by the presence of MR and also by the cause of MR being a mitral valve prolapse in various forms that it can have. It's very, the lesions can be heterogeneous, but the mechanism is always the same, type 2 with a prolapse and with various severity of regurgitation. And the main information we have on this is that the main determinant of outcome is the performance of mitral valve repair. And here you have an example of a flail posterior leaflet treated very simply by surgery, by resecting, triangular resection of the flail segment, reattachment, and then annuloplasty. And this treatment has transformed the management of mitral regurgitation. Initially, we have shown that the survival after valve repair is almost equivalent to the expected survival in the general population. So we restore life expectancy in these patients and is much better than valve replacement in those patients. But should we still insist on valve repair in the era of lower operative risk, better subvalvular preservation, and better bioprosthesis? And in fact, we looked at that with a MIDA registry that was initiated by my friend Francesco Grigioni. And in this paper, we looked at the large number of patients who underwent treatment for mitral regurgitation, and the repair is always better than the replacement, even if you match the cohort, even if you adjust for inverse probability weighing. Repair always better, and repair better than replacement at all ages, the young patients, the middle-aged patient, and the mature patients. Always repair is better than replacement. So at any age, we should insist on valve repair for the treatment of degenerative mitral regurgitation. And this is why when we look at the European guidelines, they put it a class 1 mitral valve repair when the result of the repair are expected to be durable, which in general we can achieve, although we have to improve the percent of repair done by the surgeons. And it's the same indication in the US guidelines, insisting on mitral valve repair, but here you have the distribution of how it's organized, symptoms, left ventricular dysfunction, and the guidelines indicated a green box saying, oh, now it's time to do mitral valve surgery. But we have a problem with these guidelines, is that green telling us that this is a green light to a better outcome or not? And in fact, when we looked at that and classifying the operations by the class 1 indication, class 2 due to a complication, and class 2 early surgery, we observed that the worst outcome, in fact, was after a class 1 indication. Whereas the patient who had already a complication such as pulmonary hypertension and atrial fibrillation has not as bad an outcome, but the early surgery had the best outcome of all the patients treated, even after adjustment for all covariates. So early surgery yields better outcomes than class 1 indication. So it's not a green light to a better outcome. And indeed, when we looked in degenerative MR at the effect of early surgery performed within 3 months of diagnosis. We saw that the outcome 20 years after the diagnosis is better with early surgery than medical management, even after propensity score matching of these patients. Early surgery is better because we have avoided the complication. You prevent mortality, you prevent heart failure, you do not prevent atrial fibrillation, but the outcome is generally better. So that's what we want to do for our patients. So early surgery yields better outcome than watchful waiting. What do the guidelines say and the European guidelines? And the European guidelines say, okay, you have symptoms, LV dysfunction, and they talk about atrial fibrillation or pulmonary hypertension in these patients also. And this is lacking in the US guideline. It is not obvious. It's slightly mentioned, but not obvious. And we proceed with repair mandatorily or not. But you see, these are presented as these atrial fibrillation and pulmonary hypertension as class 2 indication, not as good as the class 1 indication, not as mandatory as the class 1 indication. But in fact, atrial fibrillation, when we look at the outcome that it implies, persistent atrial fibrillation is associated with a dire outcome, with almost 30% less survival than people in sinus rhythm. And even paroxysmal atrial fibrillation is associated with a penalty in terms of survival after diagnosis. So it is very similar to the weight of the symptoms in class 3, 4. So for us, in patients with degenerative MR, we need to upgrade atrial fibrillation to a class 1 indication for surgery. And similarly, pulmonary hypertension has dire consequences under medical management. It improves after surgery, but the risk for the outcome persists even after surgery. So it's very similar to the severe symptoms that maintain a risk for the patient even after surgery. So we want to do the surgery, but it's going to be a surgery with a number of complications post-op. So in patients with degenerative MR, again, upgrade pulmonary hypertension to a class 1 indication for surgery. So if we have a patient with MR, symptoms, LV dysfunction, atrial fibrillation, pulmonary hypertension, all should be class 1. But class 1 is a misnomer. It's not like the best indication. It means that there is a high risk under medical management, and we need to palliate that. And when we do the surgery, it's going to be just a rescue surgery that relieves the symptoms, relieves the patient, but with a mediocre postoperative outcome. But what it means is that we need to do something immediately, and it is mandatory to do it. And on the other hand, we have early surgery. We do a restorative surgery where we provide no relief because the patients are asymptomatic, but we restore life expectancy. And when we have to do that, how do we balance the risk of surgery versus medical treatment? And how do we do that? Well, there are multiple factors that can help us. First, the left atrial volume. You see, we pay attention to the jets. We don't pay much attention to what contains the left atrium, but the left atrial volume is easily measurable by echo or by CT, by the way, and it has a profound impact on outcome. Under medical management, patients with LA volume index above 60 milliliter per meter square have a dire outcome. It is, and with the risk that persists post-op, while the patient with 40 to 60 milliliter per meter square have also a bad outcome, but it almost normalizes post-op versus the patient who have no atrial dilatation. So yes, left atrial enlargement, independently of any other characteristics, is very important to take into account as an objective measure that things are not so well. Hormonal response to MR also, when there is an elevation of BNP beyond the normal level for age and sex, well, you pay a price in terms of outcome, and even more when the BNP is markedly elevated. And we have to take into account the presence of hormonal activation in the indication for surgery. And then the big issue is the MR severity. How severe is the MR? And the guidelines provide number. And where does that come from, these numbers that are provided by the guidelines to judge the severity of the MR? Well, a lot of centers function with looking at the jets and making a judgment on the severity, yes, no, of the MR. But I would invite you to consider more. And the guidelines of the American Society of Echo give a number of signs to make a categorical decision on what the MR is, and mention to perform quantitative method whenever possible, not mandatory. And I would say this should be almost mandatory to quantify the MR, to get a number and to put the patient in these boxes of severity, grade 1, grade 2, grade 3, grade 4, and we can express the words here. So how do we do it for this quantification? And the method that is the most used now is the PISA, because we have not only the measurement, but a visual judgment on the size of the proximal flow convergence, and we can measure the flow, we can measure the velocity, and calculate the effective regurgitant orifice for these patients, the severity of the lesion of these patients. And in our prospective study of mitral regurgitation, organic mitral regurgitation, we saw that the people with the most severe, above 40 millimeters square of regurgitant orifice, had excess mortality. The people with the smallest orifice had a very good outcome. And in between, the moderate MR begin well, but progress over time. And there is a late mortality that was worrisome in these patients. And we're going to look at that again. And this was done by a few number of experts in quantifying MR. But does that apply to routine practice? And indeed, when we looked at thousands of patients, close to 5,000 patients, we saw that it does apply. What we measure at baseline by echo in routine practice is highly associated with outcome, with survival, which is very close to what was found in the pilot expert prospective study. It works in routine practice to separate the severe, the moderate, and the mild mitral regurgitation by quantitative criteria. And one point that is important is to look at the spline curve, comparing the risk to the general population mortality. So if you have a regurgitant orifice, no MR, or a regurgitant orifice less than 20 millimeters square, survival is identical to the expected survival. Your life expectancy is unaffected. If you have severe MR, you have a red curve where it's high risk here. But I want you to pay attention to the moderate MR, where there is an excess risk of mortality here. And the more you increase in the moderate severe range, and the more you have risk. So these patients that currently we do not consider for surgery, I believe that in the future, they should be considered for surgery, because some of them are at significant risk and should be considered for treatment. So mitral regurgitation, so if we have no risk factors that we have mentioned, we follow the patient, and it's more frequent if it's more severe mitral regurgitation. If we have symptom, LV dysfunction, atrial fibrillation, pulmonary hypertension, rescue surgery immediately without delay. And if we have those factors, the various measurements that we can make approaching or at severe status, and in particular, the effective regurgitant orifice above 40 millimeters square, then we're going to proceed with early surgery for these patients. So early surgery is low risk, yields better outcome than watchful waiting?
Time
Do
is
we
really-
fully treat the patient? What do we do with this knowledge that we have had for a number of years? Well, when we looked at the community around the Mayo Clinic, Olmsted County, Minnesota, what we see is that in organic MR of the usual age, 68, over their lifetime, only 37% were ever treated by surgery. And because of that, there is an excess mortality observed for this patient as compared to the expected survival for this population. So we do not do what we preach, and it costs dearly to the patient with mitral regurgitation. Now, physicians are risk averse. With age, we have observed that there is over time improvement in repair rates. So the repairs are better, but the risk of the operation, even though it has markedly improved, remain higher in older subjects than in younger subjects. So this risk, physicians are risk averse and do not want to take a risk. Now, to do that, you have to compare the risk of the surgery to the spontaneous risk. And this is why, with Francesco Grigioni, we have developed the MIDA mortality risk score, where we take the factor, give points, and this risk score allows under medical management to widely spray the risk attributable to the patient and how much risk there is. And you see here the highest score had a 32% survival at 5 years versus very good survival in this group. So this has been a progress in knowing the risk attributable in these patients. And we have improved this risk score with the MIDA Q mortality, where we add to the MIDA the score related to the severity of the MR. And you see here that at 5 years, the mortality sprays between 3% mortality at 5 years to 95% mortality at 5 years. And this allows to measure the risk incurred by each specific patient and to compare to the risk due to the operation and to address this undertreatment of mitral regurgitation. So it's probably related, the undertreatment, to the fear of the operative risk and the lack of DMR spontaneous risk appraisal, and we can address that by these risk scores. Now, what is recent is the edge-to-edge repair for DMR. It was initiated by my friend Ottavio Alfieri as suturing, and now it can be done by transcatheter clip. But what are the outcomes? In the Everest-2 trial that was published in the New England Journal of Medicine, the comparison to surgery showed that there was equivalence in the functional MR, but surgery was much better in degenerative MR. Does that mean that we should not use it in patients with degenerative MR? We all know that the clipping causes a marked decrease in the V wave in those patients. The LA pressure improves, the V waves is attenuated. And when we analyzed the 5 years, when the 5-year result of Everest 2 were analyzed, the risk still of surgery was lower than the risk of percutaneous repair. But the patient who had percutaneous repair, initially and long-term, had generally marked improvement in their symptoms. And because of this marked improvement in their symptoms, the clipping of the mitral valve for degenerative MR and outsized risk of the operation was approved by the FDA, and it became commercial. So the question is, okay, we are approved based on NYHA improvement, but does it affect the outcome? This has been added to the guidelines. High or prohibitive surgical risk with anatomy favorable and life expectancy above 1 year, consider transcatheter edge-to-edge mitral valve repair, but does it do anything for the outcome? And that's what we have addressed with Giovanni Benfari and a large group of collaborators, where we compared people unoperated to those who had TER treated MR, even in the match cohort. And to make a long story short, what we saw is that the survival in the people TER treated was much better than in the patients with unoperated degenerative mitral regurgitation, with a marked improvement in survival. So that is a very good point. Is we improve the outcome of these patients, there will not be a randomized study versus medical treatment now anymore, now that the treatment is approved, but we know that it does improve survival in this comparison. So we change our scheme in patients with symptom LV dysfunction, atrial fibrillation, pulmonary hypertension. If the risk is low and medium, we do a rescue surgery, which has a better result by doing a repair. But if it's high risk, we can now do a rescue clipping for this patient and improve their outcome and improve their survival. Now, the big problem with clipping and with anything for MR is residual MR. Like here, you see a residual MR in those patients. And it is associated with a bad outcome. You see, this is moderate or severe MR post-clip, and you see that the survival is not different from the unoperated patients. We do not improve the outcome of the patient if we throw a clip at the patient and we do not achieve a good control of mitral regurgitation. But this issue of the importance of residual MR is not just for the clip, it's also for surgery. When there is MR recurrence, there is a high risk imposed to the patient, and this is true for surgery. So when we have degenerative MR treated by transcatheter or surgical repair, we have an imperious necessity of continuously striving for perfection to avoid any residual mitral regurgitation, if at all possible. So in summary, DMR treatment currently, valve repair is a crucial tool to reduce the MR under treatment. Early surgical repair restores life expectancy. TEER should be a class 1 indication for high-risk symptomatic patients with severe DMR. And all repairs, that is the point, the very crucial point for the people doing the intervention. All repairs, surgical or TEER, should aim at perfection in eliminating DMR. Thank you so much for your attention.
Wonderful. Thank you so much, Maurice, for this wonderful talk, very comprehensive about degenerative mitral regurgitation. I encourage everyone that has questions to type them in the chat. I think we will keep the discussion at the end for everyone. And with that, I will introduce our next stellar speaker. It's my pleasure to introduce Rebecca Hahn, who will talk to us about secondary tricuspid regurgitation. Of course, Becky needs no introduction. She's an expert in valvular heart disease. And so take it away, Becky. Is she here?
Yes, sorry.
Oh, okay.
Yeah, sorry. Just going to try and start the talk. Can you let me know if you can see
We do.
The slides?
Yeah.
In slide format? Or in the
it's not presentation mode.
Okay. Yes. So sometimes that happens.
There you are.
Now.
Okay.
Now it's good.
All right, thank you so much. So we're going to talk about tricuspid regurgitation, and this is a rather large topic, but it's going to be quite abbreviated. But we know already that in natural history studies that tricuspid regurgitation is associated with outcomes, and it's in a graded response, so that as you have more tricuspid regurgitation, the mortality goes down. And this has been shown in not only short-term studies and medium-term studies, but this is a long-term study from the National Echocardiography Database of Australia, showing that even at the initial diagnosis of mild, that you have a 30% increase in your all-cause mortality over the course of this follow-up period, which was up to 20 years. And so we know that tricuspid regurgitation is associated with adverse outcomes, but we also know that even mild tricuspid regurgitation is associated with progression of the disease. And so this is a progressive disease. There are many other predictors of progression. And in this study, one of the highest predictors was not only just the presence of any other than none or trace tricuspid regurgitation, but left valvular surgery. So we have many patients coming into the trials, about 30 to 40% of them already have left valve surgery. And that, again, is a predictor of progression. And we know that with rapid progression, and this was within the 1.2 years from the study, that you have, again, an increased risk of adverse outcomes. Progression, we know, can be predicted by a number of different parameters. You can see in the yellow box the risk factors that was looked at in this large population-based study, and the population attributable fractions, when you then dive down into those patients who did progress, are now on the right side of the screen. So it's pulmonary artery pressures of greater than or equal to 36 millimeters of mercury. So not even very high PA pressures will predict progression of disease. Left atrial enlargement, so another sign, I think, of high left atrial filling pressures, age greater than 60, and atrial fibrillation. So we all know that AFib is a great predictor of progression of the disease. So we know from multiple studies that it is this progression that may determine outcomes, and that it's not just the TR grade itself, but we have to remember that RV function and pulmonary artery pressures play a very, very large role in the progression of the disease. And so it is this entire tricuspid RV-PA complex that we need to consider when we're talking about tricuspid regurgitation and its progression, and something that we've learned along the way. But they learned long ago that tricuspid valve is designed to become incompetent. This is a valve that, by its own construct, has very little fibrous tissue in the annulus, and goes from atrial myocardium directly into ventricular myocardium, with very little, in females particularly, very little elastic fibers or collagen. And so it is a valve that may indeed be designed to progress in severity of regurgitation. Now, this important paper has shown, and this just came out last year in early in press, showing that the number of patients who progress is actually smaller than the number that regress. So we have 18% of patients that progress, and the predictors obviously on the far right, left-hand side of the screen, but 38% of the patients regressed. And when you look at outcomes based on regression with no change in patients that started with just moderate TR was no different as far as outcomes. Whereas those that did progress, in 18% of the patients, you then saw an increase in adverse outcomes, particularly if they had progressed to massive or torrential. So again, severe, massive, and torrential we'll talk about in just a second, but the new additional grades of severe that have been designed specifically for trials, for the interventional trials. So this is just a glimpse of what the two guidelines look like as far as interventional recommendations. There's only one class 1 indication for intervention in the American guidelines, and that's at the time of left heart surgery, whereas the European guidelines state that you may also consider intervention at the time of severe TR, but without severe irreversible RV dysfunction. Now, that definition is totally unknown. So when you look at the outcomes of surgery and isolated tricuspid valve surgery, you can see that the outcomes really haven't changed over the course of decades, and it's somewhere around 8 to 10%. So these are the two fairly seminal studies showing the same percent of outcomes in Europe and as well as the United States, and that the predictors of mortality were the advanced New York Heart Association class and RV dysfunction. And so it's clear, I think, that we operate a little bit too late. In a more contemporary population, this study showed that, again, the operative outcomes when you take out those patients that were operated for endocarditis, which tend to be younger and do better, that the operative mortality is still in about 7%. And so this is not a population that most surgeons prefer to operate on. It's a sick population, the patients that we end up seeing now for transcatheter devices. But is surgery the answer? Well, in this study by Axtel, and this is a study coming out of the MGH with Jason Wasfi, they showed that when you adjusted for a mortal time bias, there was no difference in survival between patients who received medical therapy versus surgical therapy. And that's obviously in a population. There were 171 patients that underwent surgery at MGH. And so they're dealing with probably an older population of patients than the contemporary ones. But when we look at the risk factor, or the risks or the patient characteristics of those patients now presenting for the transcatheter therapies, they're probably similar to the patients that ended up going to surgery in the MGH study. And so there is quite a bit of difference, though. And so it's worth looking at those a little bit more closely. When you look at and this is in press now, so should come out shortly. And I'm sorry that the typeface is so small, but the Triluminate, both the TEER group versus control, and then the Trisend, which was the replacement device. So Triluminate was TEER, Trisend is replacement. You can see the differences in a number of different baseline characteristics. In the patients with Trisend, they tended to be older, they tended to be female, they had higher New York Heart Association class 3 and 4, they had more renal dysfunction, they had lower ejection fractions and therefore probably more ventricular secondary disease. They had a greater number of prior pacemakers, CIEDs, cardiac implantable electronic devices. And we know from multiple studies, including one from the NEDA database, that pacemakers in and of itself, whether they're causing or just incidental, pacemakers themselves predict outcomes. And so they also have a lower KCCQ score. And those are the patients that tend to be able to see greater improvement. And then they also had more heart failure hospitalizations in the prior year. And so this kind of sets us up for possible differences between the trials and between the outcomes of the two different devices. Now, why do we operate too late and too little? Those, again, are the patients that never went to surgery, the ones that you just saw. Well, it's the protein signs and symptoms, which may be easily attributed to aging. So some edema, some increase in abdominal girth. Are they just gaining weight, or is it really ascites? The diagnostic difficulties by echocardiography, and then the limited guideline definitions for both optimal medical therapy, progression of TR, so is annual dilatation really sufficient, which we obviously don't think that it is, and then the severe versus and irreversible RV dysfunction. So these are really poorly defined. Now, we have guidelines for quantitating severity of tricuspid regurgitation, both in the US and in Europe. In Europe, they've gone ahead and adopted the increased grading scheme for severe, but mainly for those patients that are being considered for transcatheter tricuspid valve repair. So remember, again, in routine practice, we still are grading it by mild, moderate, and severe. But both guidelines, and as Maurice has already said, quantitation is so important. And the guidelines are very clear that quantitative evaluation, whenever possible, is what we should do. But the major issue with TR is just its tremendous dependence on loading conditions and its frequent non-circular, non-planar orifice. And so we can use PISA, but you can see here again that in this biplane image that the PISA is really a hemiellipse and not a hemisphere. And therefore, making it very obvious that in many cases of TR, we are underestimating based on PISA. It is easy to measure, but obviously not tended to be used for multiple jets. Non-circular and complex orifice shapes, as I'm showing you here, may be an issue. And then frequently when we have functional disease, we have tethering of the leaflets, and therefore we may not be able to accurately assess. And that was really beautifully shown by this study coming out of Denise Muraro's lab, looking at, again, the ability ability to correct for some of those issues with the PISA, current PISA calculation, specifically for TR. TR is just almost always functional disease, almost always with the tethering. It is a low velocity site. So she corrected for two of those aspects and found that you could indeed improve on the quantification compared to a quantitative Doppler assessment. And so we are currently underestimating using just PISA. You can correct, obviously, for tethering, but there are other correction factors that may be important. But nonetheless, PISA is highly predictive of outcomes, and we should never not do PISA. PISA should always be done. These are multiple studies, and there are many more that show that outcomes clearly defined by quantitative metrics. It's just that if you're not going to correct, then you should understand that you may be underestimating by up to 40% the true severity of the regurgitation orifice, and therefore perhaps send to a level 1, what we call a level 1 in the US valvular heart center, who can use other measures of quantitation. So this is one of those other measures of quantitation from our core lab, which uses 3D vena contracta area, as well as we've used quantitative Doppler measures in order to really understand the severity of the regurgitation. And the 3D VCA has been validated in other labs as well. And so we do believe that, and we average over the systolic time interval in order to get a better, an accurate assessment, given the time variability of the disease, the temporal variability of TR. And so we know that 3D VCA may become a major way that we can quantify. Now, you all are familiar with the increased grading scheme that it was proposed really for the trials because some of the devices were showing a 1-grade reduction in TR, but couldn't get below severe. So we would have to say severe to severe. And then obviously it really encumbered the conclusions and the advancements of device therapy, because then the surgeons kept arguing with me, well, you went from severe to severe. How could that be, how could that have any outcomes associated with it? But we now know from multiple studies that even a single grade reduction from massive to torrential will indeed improve the KCCQ score by around 5%. And so reduction of disease based on this extended grading scheme, we think, has outcomes associated with it. And that was shown by multiple studies. So these are just a smattering of all the studies that have now tried to look at these extended grading schemes, finding indeed that there might be a continuous hazard with, for instance, EROA by PISA. And that's the last study there by Fortuny. So again, please quantify. We know that both by natural history studies, which I just showed you now, as well as all of these studies that were in patients that received transcatheter devices, that massive and torrential disease, it's much harder to get down to mild disease, which we believe is extremely important for outcomes. And so therefore, for those patients, we think that the new extended grading scheme is very useful, and the US guidelines should be amended to correlate with the European guidelines. Now, medical therapy is going to be also an issue. European guidelines did not want to give levels of recommendation for therapy because there is no data. The US guidelines gave 2A recommendations for a diuretic. I mean, it seems kind of silly, like that should be a class 1, but there's no data. And so in all guidelines recommend that you treat the other disease processes. So any disease process secondary to heart failure on the left side, whether it be heart failure with reduced or preserved ejection fraction, and then rhythm control, because again, we have multiple studies showing that conversion, either active or passive or spontaneous conversion to normal sinus rhythm, will reduce the chamber sizes in those patients that had atrial fibrillation, and therefore also are associated with a reduction in both mitral and tricuspid regurgitation. So atrial fibrillation control, and again, as Maurice has said, AFib portends a worse prognosis with all of our patients with AV valve regurgitation. But the European guidelines were able to say, because they had approved devices, that none of those things, initiating medical therapy is great, but you should not delay therapy with surgery or transcatheter devices. And so we need more data in order to change our US guidelines. But I do think that the European guidelines have it right, that we should not be delaying therapy. Now, what do we know about medical therapy? Well, we know that TEER devices, so reducing mitral regurgitation, is going to affect outcomes as well as the severity of TR. So you reduce the amount of TR by reducing the amount of mitral regurgitation. We also know that CRT, treatment for left-sided failure, also reduces tricuspid regurgitation by 22%. And those patients that reduce regurg have a better outcome. This is the study on atrial fibrillation. And then we have an interesting poll that was taken of physicians that treated pulmonary hypertension, asking what would stimulate an escalation of treatment for pulmonary hypertension. And the majority of these pollants, these clinicians, said that echocardiographic parameters of pericardial effusion and tricuspid regurgitation were at the very top of the list for indications for escalation of therapy of pulmonary hypertension. So we do believe that the guidelines have it right as far as treating aggressively the left-sided disease as well as pulmonary hypertension. But what about the definitions of when to intervene for right heart failure? We really just don't know. What will predict recovery of RV function? We don't even have guidelines that give us divisions of mild, moderate, and severe dysfunction. So the TVARC, which is an academic research consortium, is not a guideline, but it is a consensus document that attempted to propose grading of function in order to see whether or not really outcomes were determined by any of these metrics. And these are primarily echocardiographic metrics. We obviously should probably have added other metrics like CMR. And we strayed away a little from putting our money down on a number for RVPI coupling. So RVPI coupling, again, one of the most important measures that we believe will characterize that RV response to pulmonary hypertension, to an increase in PA pressure. And remember, just an increase in PA systolic pressure to 36 millimeters of mercury will determine progression of disease. And so some of the other studies that have been important are from Philip Lurtz and from Mickey Brenner, our fellow that looked at the tri-valve registry, looking at RVPA coupling by TAPSE divided by SPAP, so systolic PA pressure. But what this comes out of Jörg Hausleiter's lab, what Lucas Stolz showed was that if you used invasive measures of SPAP, you improve the prediction of outcomes in patients that receive the TEER device. So you improve it over the non-invasive SPAP, and that's because we've got some issues with non-invasive SPAP with echo. And we wrote this editorial with Catherine Otto based on a study, a beautiful study that showed the discordance between echo and invasive PA pressures. But almost all of the difference came from right atrial pressure assessments. And we just don't have great right atrial pressure assessments by echo. But this study has just come out also looking at invasive TAPSE over PASP and showed beautifully that we have no idea by echo how to grade the right atrial pressure. So all across the board, lots of different invasive PA, even 30 millimeters of mercury for the RA pressure when we estimated it as 3. And so it's just, we can't estimate yet accurately the RA pressure, and that's going to be the issue. And toward that end, Denise Moraro again showed beautifully that if we could just avoid the PASP and use a different metric of RVPA coupling, could we predict outcomes better? And indeed, she showed that just using forward stroke volume divided by end systolic volume, we have a beautiful predictor of outcomes. And you can see here again that on the AUCs that stroke volume divided by end systolic volume was a better predictor than those non-invasive measures that ended up using SPAP. So what about the guidelines? Again, we know that the outcomes are bad and we operate too late. Oh, sorry. We seem to be repeating ourselves. Just to say, we know that we have multiple risk scores, right? So this is just a beautiful review that's just come out looking at all the different risk scores and how we can assess our patients. And it turns out that, RV function and RV failure becomes a major predictor of the outcomes. And so we know from other surgical studies that we're just operating too late, and we need to either use, scores like the MELD score or the MELD-XI score in order to try and get to the patients a little bit earlier. But what we also know is that now that we have transcatheter device therapies, and so the yellow stars are the ones that are approved in Europe, and now the red stars are the ones approved by the FDA in the United States, that we now have transcatheter therapies that may avoid some of the other complications of surgical intervention. But indeed, one has to remember that we've not shown in the randomized trials yet mortality and heart failure hospital benefit. But Anna Sanino's beautiful meta-analysis, which I always quote, showed that the hope was there, that we should be improving clinical outcomes. We know we can reduce annular dimensions and we can cause remodeling of the RV, so decrease in RV basal diameters, but also RV size. We know that function will go down because of the increase in effective afterload, but there should be an increase in forward stroke volume. And when you compare to propensity matched groups treated medically, those patients improve. But what we know is that we have to get the TR down to mild, okay, or at most 2+. So this is a study that will just be published. It'll be simultaneously published with the presentation at Europe PCR, showing again that you have to get it down to at least 2+ and preferably 1. And that may be one of the main differences then between the TEER devices and the TTVR devices. We know that in the TRISCEND study, you can take it down to 0 in 98% of patients. And in that setting, you can improve cardiac output and forward stroke volume, which is what we hope for. And that is why the FDA approved the Evoque device, because of all the positive trends in the early look at the patients that got the Evoque device. All the trends were positive. Looked like we were going to have heart failure and mortality improvement, clearly had KCCQ and heart failure hospitalization benefit, as well as an increase in cardiac output and stroke volume. But remember that when you're deciding between two devices, we've got a number of other possible problems that you need to consider. And we've outlined those in this current cardiology report. Again, it's in press. It should come out soon. And this is also in that document where our decision-making process is very complex. And so we know that we have two devices now approved by the FDA, but the decision-making regarding those devices remain very, very complex. And the indications for use could only be for improvement in KCCQ. And so we know in summary that TR is a heterogeneous population. The diagnosis is delayed because of late and nonspecific symptoms with difficulty quantifying severity. Natural history outcomes are determined, however, by the TR etiology and severity. We don't know what medical therapy should be. And then isolated tricuspid valve surgery is associated with high in-hospital mortality. But if we get to all of our patients earlier, these may improve. And right now, we believe the guidelines should be updated, particularly in the setting now of 2 FDA-approved devices. Thanks for your attention.
Thank you, Becky, for this terrific summary of a rapidly evolving field like tricuspid regurgitation. Once again, any question from the audience can be written on the chat, and we will have the discussion at the end. Now we move from regurgitation valve to stenotic valve, and it's my great pleasure to invite one researcher that has really made the history of aortic stenosis, Professor Philippe Barrault from Quebec, about what to do with patients with aortic stenosis. Thank you, Phil, for joining.
Buongiorno a tutti, grazie mille, Luigi. And my Italian stops here, so I will continue in English. Early valve replacement in aortic stenosis. Do we have some new stuff for the guidelines? So these are my disclosure. And in the guidelines, you have this notion of the progression stages where you have the patient at risk for AS. This includes bicuspid valve, aortic sclerosis. And then you have the stage B, where you have progression to mild moderate AS. And for these two categories of stages, what is recommended is to follow the patient by echo, and clinically there is no indication for intervention. And when the stenosis becomes now too severe, but there is no symptoms, no LV dysfunction, this is where we have a dilemma for this asymptomatic CVIS. Should we intervene earlier or watchful waiting / clinical surveillance? And then, of course, you have those patients where there is CVIS and class 1 indication for intervention based on presence of symptoms or LV dysfunction, which in the guidelines is defined as EF less than 50%. So the first new frontier I would like to discuss with you is this issue of early AVR versus clinical surveillance in the asymptomatic CVIS. And this is an example of a patient, 75-year-old woman. She has calcific AS. She's true asymptomatic, so she underwent an exercise testing, did a good test. She has a somewhat elevated BNP. The BNP ratio is 2 versus her age and sex upper normal range. LVF is 60%, so this is a preserved EF. And as you can appreciate, the valve is severely calcified, thickened with rest-use opening, and there is a very severe ES. Peak jet velocity is 5.1. By the way, 1 year ago, it's 4.8 meters per second, so we have a rapid progression in this patient. Remember, in the guidelines, rapid progression is defined as more than 0.3 meters per second per year. Mean gradient is 64, valve area by continuity is 0.65, so by all means, this is a very severe ES in a asymptomatic patient. So what should we do? Should we do an early, quote-unquote, prophylactic AVR or watchful waiting? If you look at the guidelines for this patient with asymptomatic CVIS, there is not yet any class 1 indication for valve replacement unless the LVF is less than 50% or there is an indication for another cardiac surgery. But you do have some 2A indication if the stenosis is very severe, if there is a markedly elevated BNP ratio defined as a ratio more than 3, or if there is a rapid disease progression. So actually, the patient I just showed you has at least 2 criteria among these 2 indications, so could be considered for an earlier intervention. Okay, so if you, as you saw in the guidelines, what you have and the trigger for intervention are essentially based on severity of AS, presence of symptoms, and or LVF less than 50%. And of course, we need to look at the left ventricle and the other cardiac chamber to trigger eventually intervention in asymptomatic CVIS. And if we look at the LV ejection fraction, we may conclude that, you know, you have a beautiful day with a beautiful sky and everything is doing well with regard to LV function. But if you look at other parameters that are more sensitive, the conclusion might be different. And it's very important to keep in mind that the LVEF grossly underestimate the extent of myocardial dysfunction and subclinical dysfunction in patients with AS because it is confounded or it is masked by the LV concentric hypertrophy that we often have in these patients. And indeed, if you look at several studies, including this study from the Mayo, where you see that if you have an LVEF more than 60%, you do fine. If you have LVEF less than 50%, that's the red curve. Of course, there is an impact on mortality and on a short term. But LVEF between 50 and 60 that would be considered according to the guidelines as normal LV function, no problem, actually have a markedly reduced survival compared to patients with LVF more than 60%, and initially close to those with less than 50%. So I think there is an important take-home message here is that this cut, the LVF less than 60% actually may be more appropriate to define LV dysfunction and trigger AVR in patient. And maybe this LVF less than 50% that we have in the guidelines is too low and lacks sensitivity. And indeed, in the last edition of the guidelines, you have now a new indication for AVR if the LVF declines below 60%, not 50, and it's a 2B indication in the American guidelines. The European guidelines used a somewhat different direction. They use a lower cut point for LVF, so 55%, but with stronger indication, so a 2A. And again, remember that what our eyes see, so the LV ejection fraction, is not necessarily what our heart or the heart of your patient is feeling, and that the LVF underestimate the dysfunction and lacks sensitivity to detect subclinical dysfunction. And so we may either raise the cut point for LVF or use other parameters such as the global longitudinal strain that we can easily measure by speckle tracking. There is now auto strain module on the Doppler echo machine. And you realize from this meta-analysis that even even in the subgroup of patients who have EF more than 60%, and where you would say, oh, this patient, they certainly do not have subclinical dysfunction. Well, 1/3 have substantially reduced longitudinal function, a global longitudinal strain less than 50% or -15. And if they do so, they have reduced survival, and not in 5 or 10 years, in the short term, within the first year. So another way to, better assess the repercussion of the disease on the LV function and maybe consider earlier intervention is to use the BNP. And this elegant study from Marie-Annie Clavel, and when she was at the Mayo Clinic with Maurice Sarano, showed that if you have a BNP ratio that is more than 2, so compared to the upper normal range for age and sex, you'll start seeing some increase in mortality. And when it's getting more than 3, of course, that's the red curve, and that's what now is in the guideline. There is a worse prognosis in the short term and high risk of mortality. So I'm trying to advance the slide. Okay, we made some progress. We had a better look at the left ventricle, but remember, the heart has 4 chambers, and we need to consider all chambers to have optimal risk stratification. And I think we can do a parallel with what colleagues do in oncology, where the assessment and the risk stratification and therapeutic decision-making is based on a twofold assessment: grading of the severity of the primary tumor, but also staging of the extension of the metastasis of the tumor. And we should do the same in cardiology, and in particular in AS. Well, of course, we need to grade the severity of AS, and we need to do it well: mild, moderate, severe, very severe. But we also need to stage the extension of extravalvular cardiac damage, because in fine, what determines the prognosis of the patient is not directly the severity of the aortic valve disease, but more the repercussion of this disease on the cardiac chamber geometry and function. So for this purpose, we proposed a simple classification with Philippe Généreux from Morristown that is based on echo parameters in order to stage the extension of cardiac damage. And this is the classification that we propose for the asymptomatic severe ES. So stage 1, left ventricular damage with increased LV mass, grade 2 or more diastolic dysfunction, EF less than 60, not 50, based on the studies I showed you. And we also added the global longitudinal strain with a cut point of 15%. And if you have one of the criteria, you don't need all, you qualify for stage 1. And then we go upstream. Stage 2, left atrial mitral valve damage with enlarged left atrium, moderate severe MR, and or AFib, which is the only non-echo criteria in this classification, but it is so important. Stage 3, pulmonary arterial tricuspid valve damage with pulmonary hypertension, moderate severe TR, and stage 4, moderate severe RV dysfunction and or moderate or severe low flow state. And so we applied this classification to an international multi-center study of heart valve clinics with patients with asymptomatic severe ES, and if we're true asymptomatic severe ES, and we're struck by the results. 61% of these asymptomatic patients actually had advanced cardiac damage, so stage 2, 3, or 4. And if they had stage 2, which is the red curve, or 3, 4, that is the black curve, you see an increase in the risk of mortality, again in the short term. So I think there is an important take-home message here, is that the absence of symptom in this patient with severe ES is falsely reassuring and does not imply there is no cardiac damage and not increased risk for events. So when there is no symptoms, I think we need to better look at the echo and do this staging. So what we do with Philippe Généreux in a pooled analysis of partner 2 and 3, we look at the evolution of the staging following aortic valve replacement in these patients. We pulled together TAVR and SAVR. And this was a cold shower, I would say, because we found that only 15.6% of the patient will improve their cardiac damage stage before pre-AVR to 1 year post-AVR. 57.9% was status quo, and even a 26.5% actually had a worsening of the stage. And if they had a worsening of the stage, this was associated with a 2.25-fold increase in mortality subsequently. And the two factors associated with this worst case scenario, worsening of staging, where hypertension, just reminding us that when we treat AS, we also need to treat aggressively the comorbidities, hypertension, diabetes, coronary artery disease, amyloidosis, etc., if we don't want the AVR to be futile. And second, the second factor was SAVR rather than TAVR, essentially because SAVR was associated with new onset or worsening of RV dysfunction, so stage 3-4 essentially. So this summarizes how we can implement this cardiac damage staging into practice and eventually implement in the guidelines. For these asymptomatic severe AS patients, such as the patient I showed you, I think a stage 2 or more should be an argument to consider an earlier intervention. I think it's ready for prime time in the guidelines, and we already had several studies that validated this, I think, this finding. And as we'll see in the next last part of the presentation, the same could be applied to at-risk moderate AS. When you have advanced cardiac damage stage, this is maybe where we should consider earlier intervention in moderate AS if the future trial validate this hypothesis. And for the symptomatic severe AS, we already have an indication for AVR. The staging may be useful to consider one intervention versus the other there. And if you have a stage 3 or 4, I think this should be an argument for considering a TAVR versus a SAVR. So as you know, there has been already some small trials performed to compare early surgery versus conservative management in asymptomatic very severe AS, and showing superiority of an earlier surgery versus conservative care. And there are some trials that are ongoing, recruitment completed, such as the early TAVR. We're waiting for the result this year. Well, actually, the patient with asymptomatic severe, and it's not only very severe, it's all comer, that were confirmed to be asymptomatic by treadmill were randomized to TAVR versus clinical surveillance. So I think in summary, for now, there is no class 1 indication for this asymptomatic severe AS patient. There's some 2As, and this new 2B indication, the FLVF, falls below 60%. And we already discussed the potential utility and implementation of the cardiac damage stage. And stay tuned, because we have several trials ongoing for this patient with asymptomatic CV. Another new frontier, and maybe more a future perspective, is same dilemma, early AVR versus clinical surveillance, but now it's in symptomatic at-risk moderate AS. So kind of more provocative, let's say. Because in the guidelines, as of now, there is no indication for intervention in the patient with moderate AS unless there is an indication for another cardiac surgery. But if you look at this patient with very low LVF to start with, discordant gradient with low gradient at rest, where we do a dobutamine stress echo to confirm the stenosis severity. And this patient, fortunately, has some flow reserve, so the LVF increases, the flow increases, the mean gradient increase, but it's still moderate, 32 at the end of the dobutamine stress echo. And the valve area, that is severe at rest, is now moderate. So the dobutamine stress echo has reconciled the findings of valve area and gradients and tell you this stenosis is not severe, so no indication for intervention according to guidelines. This is moderate AS, fine. But is this moderate AS really benign for this failing ventricle with an LVF of 25%? So the answer is no. Because if you look first to all comers with AS, and this is this huge national registry from Australia, the NIDA registry, you see that even if you have mild AS, which is a green curve, you start to see some impact on mortality, reduced survival. But look at the curve for moderate AS, the purple one. The outcome is almost as bad as severe AS, especially during the first years. So moderate AS is not benign. And if you translate this to the context of patient with systolic heart failure, such as the patient I showed you, this is even worse. You see here the patient with moderate AS and LVF less than 50% have a very poor prognosis compared to patients with mild AS. And this is a more recent study where they compared in a propensity score match analysis a TAVR, so kind of early TAVR, if you will, versus conservative medical management in patients with moderate AS confirmed by CT CASM scoring. And actually, the outcome is much better with intervention. Of course, it's not randomized, and we need randomized trial. And there is this TAVR Unload trial. The recruitment is completed. It's actually not 300. We ended up with less patients, but the patients with moderate AS, systolic heart failure, exactly just the patient I showed you, are randomized to TAVR versus optimized heart failure therapy alone. And we'll present the result later this year. And another trial that is ongoing, well, recruitment is completed now, is the PROGRESS trial. It's a larger magnitude trial versus TAVR Unload. It's more, it's not a whole comer, it's still moderate AS with evidence of cardiac damage or dysfunction according to the classification I showed you. And these patients, 750 patients, are randomized to TAVR versus clinical surveillance with similar endpoint as early TAVR, which is death, stroke, or rehospitalization at 2 years. So this is a map, if you will, of the different trials according to grading of AS severity that is on the left column, mild, moderate, severe, asymptomatic, symptomatic, and on the other columns, the staging that I showed you. And for the for the symptomatic severe AS, we already have indication for intervention, fine. But for the asymptomatic severe AS, the first case I presented, there are actually several trials, early TAVR, but there is also EVOLVE and AVATAR and EASY-AS. And for the moderate AS and evidence of advanced cardiac damage stage, there is a TAVR Unload PROGRESS. Recruitment is completed, and EXPAND TAVR 2 still recruiting. So moderate AS is well tolerated by a good ventricle, but poorly tolerated by a failing ventricle or a ventricle with any evidence of cardiac damage and dysfunction, where here it's associated with poor prognosis. So don't take me wrong. As of now, there is no indication for AVR in patients with moderate AS. We have to wait for the trial that's ongoing to change the guidelines and eventually our practice, and eventually consider earlier intervention in moderate AS that is at risk with heavy evidence of cardiac damage, dysfunction, or symptoms. I think for now, when you have patients with moderate AS and who have evidence of cardiac damage stage 2, 3, or 4, or symptomatic, who have systolic heart failure, fortiori, I think they deserve a closer clinical and echo follow-up. So thank you very much for your attention.
Thank you so much, Philippe. That was a great talk, a great overview about aortic stenosis, and of course you are the expert on it, so thank you very much for covering it. And I think we're going to move on to the next and last speaker. It's my pleasure to introduce Patricia Pelica from Mayo Clinic, who's going to talk to us about aortic regurgitation and the new frontiers in this horizon. Thank you, Patricia.
Thank you very much. It's a pleasure to be a part of this exciting symposium. Can you see my slides now?
Not yet. We can see you, though.
No?
Not yet, Patty. Yeah. I would wait just a couple of minutes to allow Patty to share the screen. Matti, do you want we make some discussion while you are fixing the computer?
Okay, I have two monitors here. It must be the wrong
Okay.
one.
Okay.
Does it, do you have, you still don't see it?
No, not yet. But we are just seeing you, not your computer. So probably in the lower part of the screen, there is this share screen green button.
Yes, I pressed that.
And there usually gives you the option to select which screen you actually want to share.
Another option, Patty, is to instead of sharing a screen, you have the option with Zoom to share the application.
Now,
there we go.
Okay, we see them.
Perfect.
Is it in
Yeah.
present mode?
Just put them in the
slideshow
presentation mode. Yeah.
Exactly.
It's in presenter mode now?
Not yet.
Yeah.
Still,
Yes, now it's good.
okay, great, thank you. Thank you, Dr. Sonnino and Dr. Badano, for including me in this presentation. Regarding, is it time to change the guidelines for aortic regurgitation? Well, the guidelines are excellent and very carefully thought out. But the short answer is yes, it is time to change the guidelines. The evidence is progressing extremely rapidly. These are my disclosures. This is a summary, a comparison of the European and ACC guidelines for timing of intervention in chronic aortic regurgitation. Both sets of guidelines, of course, give a class of evidence, a class of recommendation of 1 for symptomatic severe aortic regurgitation. But the ratings of the level of evidence and the class change a little bit for the asymptomatic patients. The guidelines pay quite a bit of attention to linear dimensions, and the parameters for ejection fraction are slightly different for the two sets of guidelines. Also, the class of recommendation for patients undergoing cardiac surgery for other indications is slightly different for the two sets of guidelines. The ACC guidelines also include a 2B recommendation if there's a progressive decline in ejection fraction or increase in left ventricular end diastolic dimension to more than 65 millimeters. The ACC guidelines also go so far as to say that it is that TAVR should not be performed in patients that have an indication for surgical AVR. We've been quite interested in this subject and have examined the surgical indications for patients undergoing aortic valve surgery for aortic regurgitation at Mayo Clinic. The results are shown in this Venn diagram. You can see that most of the patients had class 1 indications for surgery, and in most of those, it was symptoms. Smaller numbers had surgery for aortic dilatation or for left ventricular ejection fraction less than 50%. Class 2 indications, however, were present in some patients, a total of 77 in this entire cohort, and no class 1 indications. And these included class 2 indications in 50 and no class 2 indications in 27 patients who just opted for early aortic valve replacement. So how did these patients do? Shown here are the Kaplan-Meier survival curves after aortic valve surgery, separated on the basis of class 1 indications for surgery. And you will see that the patients who had those class 1 indications did not do as well. These were largely symptomatic patients, and they were older, had more comorbidities, more advanced diastolic dysfunction, and other parameters by echocardiography indicating worse function. They also had a lower diastolic blood pressure and a smaller regurgitant volume. So interesting that the patients that were asymptomatic really did better with aortic valve surgery than waiting for patients to develop symptoms. We also looked at overall survival by left ventricular end systolic dimension indexed for body surface area in the entire cohort. So this was operated and non-operated patients. And in this spline model, we showed that 5-year survival started to deteriorate in patients with left ventricular end systolic dimension index more than 20 millimeters per meter squared. And this is particularly important. The end systolic dimension index was the only LV criterion that was linked to mortality in this cohort. Important particularly for women because they had smaller left ventricular end diastolic and systolic dimensions and smaller body surface area, but their LV end systolic dimension index was actually larger. So I think we can conclude from our studies and others that waiting for symptoms may not always be optimal in patients with severe aortic regurgitation. Additionally, we should be using indexed dimensions, particularly in patients that are smaller, and that usually includes women. Echocardiography is indeed our bedside assessment method, most common method used to recognize aortic regurgitation. Shown here, of course, is a dramatic example of aortic dissection with prolapse of the entire dissection flap across the valve. And although CMR and CT are also useful, echo is really most often used for quantitative assessment of severity of aortic regurgitation. We try to use the PISA method to quantitate aortic regurgitation. And shown here is that method. We shift the aliasing velocity in the direction of the regurgitant jet. And we calculate the regurgitant volume by multiplying the effective regurgitant orifice by the aortic valve diastolic time velocity integral. An ERO area of greater than or equal to 0.3 centimeters squared and a regurgitant volume of more than 60 cc's suggests severe aortic regurgitation. Now, the guidelines talk quite a bit about measuring these dimensions, but I think all of us who work in echo labs and follow patients longitudinally have recognized that sometimes the remodeling in aortic regurgitation is not the same if you use volumetrics and linear dimensions. This is an example of that. In this patient who was followed with echocardiography for chronic severe aortic regurgitation, and this is 3 years later, you can see that the end diastolic dimension and end systolic dimensions haven't changed much, but the volumes have changed quite a lot. The LV can remodel to a greater extent if you look at volumetric dimensions, and these are important in following these patients. So the valve guidelines refer to indexed linear dimensions, but the echo guidelines always talk about volumetric dimensions. And we were interested in comparing those. We looked at 1,100 consecutive patients with chronic moderate to severe and severe aortic regurgitation on echocardiography and performed biplane Simpson assessment. Biplane Simpson was, the Simpson method was not feasible in 7%, and we had to use monoplane in 15%. But it was really this assessment, the left ventricular, the index left ventricular and systolic volume index, that was associated with mortality. And this was true whether we censored at AVR or did not. This shows the relationship between volume and linear dimensions. And you can see the relationship is far from perfect in these patients. We also looked at the correlations between observers, because this is sometimes a criticism of biplane methods, that it's harder to do and the less reproducible, and it was really quite satisfactory. So we think that measurements we should be using volumetric measurements rather than linear dimensions to follow our patients. We've also been interested in the predictors of progression of aortic regurgitation. And here we looked at patients with stage B aortic regurgitation, which is of course progressive. And we looked at the progression to stage C, which is asymptomatic severe, and D, symptomatic severe. And at a median follow-up of 4.1 years, progression occurred in 21%. And looking at the rates of progression, it seems that the guidelines that suggest repeating an echo for trivial or mild aortic regurgitation at 5 years, and mild to moderate at 3 years, and moderate AR at 1 year are appropriate. However, we were able to identify certain predictors of more rapid progression, and these included the baseline severity of aortic regurgitation as measured by the effective regurgitant orifice area and regurgitant volume. Also, though, the aortic annulus dimension and the sinotubular junction measurements were related to progression. So these measurements should also be obtained when we evaluate our patients with chronic aortic regurgitation. Shown here is the relationship of baseline severity to progression in these patients. And you can see that in the patients with more severe aortic regurgitation, moderate aortic regurgitation at baseline, were more apt to progress. Another important parameter is the left ventricular global longitudinal strain. And we and others have noted that this is related to outcome in patients that are asymptomatic and have chronic aortic regurgitation. This was a study in 550 patients, and shown here are the spline curves comparing the relative risks of death compared to population survival for medical surveillance, and also for the total follow-up of patients, regardless of whether they were operated on. You can see here that the cut point was 15%. That was the particular cut point for identifying risk. And index left ventricular and systolic volume was also important in identifying risk. Pulmonary hypertension is another marker of increased risk. And we noted that in patients with chronic severe aortic regurgitation, 14% had a right ventricular systolic pressure of more than 41 millimeters mercury. However, the aortic valve replacement reduced the mortality similarly in those with and without pulmonary hypertension. And right ventricular systolic pressure decreased at dismissal already, and further decreased during follow-up in many of these patients. Mortality was increased in patients with pulmonary hypertension. So we should be paying attention to what the right ventricular systolic pressure is. But these patients will benefit from aortic valve intervention. Finally, machine learning can also be applied to assess risk at the point of care. And this is a model that we built using clinical variables and comorbidities, patient demographics, as well as the echo variables to identify patients at risk of mortality in chronic aortic regurgitation. And I think increasingly we're going to be using models like this at the bedside. So in summary, the left ventricular volume measurements are superior to linear dimensions. Measurements should be indexed to body surface area, particularly important for smaller patients and women where absolute dimensions may not reach the cut points. Progression is related to the baseline severity of aortic regurgitation and dimensions of the annulus and sinotubular junction. Pulmonary hypertension and abnormal left ventricular global longitudinal strain identify patients at increased risk, and machine learning also appears useful for risk stratification. And of course, no discussion of this topic would be complete without mentioning the tremendous progress that is being made with transcatheter therapies for patients with aortic regurgitation. Shown here are slides from the JenaValve trilogy paper published in Lancet, in which this has been shown to be safe and effective in 180 patients with moderate to severe or severe aortic regurgitation who were at high risk and had improvement in 30-day mortality, 6-minute walk, and New York Heart Association class with this intervention. And I thank you for your attention.
Thank you so much, Patricia. It was perfect timing. We are unfortunately running a bit late for a time that we were allocated for this webinar, but it was a terrific talk about aortic regurgitation. And I think we had really stellar speakers today. Some of the questions were already addressed in the chat, I noticed. Therefore, I will just take a moment to sort of sum up what we have heard here. We had very great talks about the latest evidence on the most prevalent valvular heart disease, stellar speakers that obviously needed no introduction. I would really like to thank each of you for joining us today, for taking the time to participate in this webinar. And of course, also thank you to all the people that joined the webinar and that connected and listened to these amazing presentations. I don't know, Luigi, if you want to add something. If not, we'll thank you and see you again very soon.
I just have taken a picture of this great moment and just thank you to Patty, Becky, Phil, and Maurice. I know how busy you are, and I am really, really grateful for you devoted your time to our education. Thank you. Ciao.
Thank you so much.
Ciao.